Okay, hello and welcome. My name is Steve Quinnan and thank you for joining us. My pleasure today to get to introduce you, tell you a little bit about myself and give you an introduction to the innovations in limb salvage and an all-internal solution to bone transport. And we'll go through sort of what that means and some other things. What I'd like to say to start is when we get toward the end or any time that you feel that you have a question during this discussion, feel free to post that on the chat, and when we're all done, we'll certainly address that. Even if you're watching this after the fact, if you post it on, we will get back to you by email and respond to your question. So first thing, a little bit about myself and my background, how I ended up here and what I've done before. So I went to medical school in New York City at Columbia University, and following that I did my residency education and an affiliated program there. I then went to Baltimore and did fellowship in orthopedic trauma at the Shock Trauma Center there. It's a well-known place for orthopedic trauma. And after that, I did something a little more unusual, not as common, did additional training in limb lengthening and deformity correction. And that was done in Brisbane, Australia, at the Royal Brisbane Hospital, which you see there. So it was a ways away. Got some additional experience that paired very well with the trauma experience I already had, and then came back to the United States, and specifically to the University of Miami and the Ryder Trauma Center in Miami, which is one of the major trauma centers here in the United States. So I was there approximately 12 years, and I rose to be the Chief of Orthopedic Trauma. During my time there, I focused on a number of things, but one of them that was of great interest was the reconstruction and restoration of the severely injured extremity, especially lower extremities. And in particular, one of the aspects of that is treatment of bone loss. That really is what paired well with the Paley Institute, and one of the reasons that I ended up joining Dr. Paley and the rest of the talented crew here in West Palm Beach at the Paley Institute. So my skills are very well suited to this group, but in particular, my take is a little different in that I'm very focused and very accomplished in adult reconstruction and post-traumatic reconstruction of the lower extremities, pelvis, and acetabulum. So that being said, what is limb salvage reconstruction? So I'll give you an example to help explain it. What it boils down to is things like this. Okay, that's a very severe injury. There's a fracture, bone missing on the street, and for those who are sensitive to pictures may want to shield your eyes, but this is basically a picture of what one of those extremities may look like. Has a large amount of skin loss, possible injury to the nerves, arteries, and veins, other things that will need to be put back together, restored and made right in order to have a properly functioning limb. And this can be difficult work. One of the parts that's difficult is management of the bone. And if we look here, we have another question. So what is a bone defect? So a bone defect, especially in reference to reconstruction of an extremity, is an area of bone loss that has occurred. And there can be a number of reasons that lead to this. The first, acute trauma, we already talked about that. Bone can be lost from a bad injury from a variety of mechanisms, car accidents, falls, other things of that nature. And that would certainly be a big part of putting this back together, be treating the bone. There are other aspects as well, though. Apart from the trauma itself, we have tumors or cancer. Now, sometimes the cancer or tumor can eat away at bone, so it's true directly it can cause that. But more often, it's the treatment that in order to cure the problem, it requires a segmental resection of an area of that bone, as you see in this example here. So there was bone there, but in order to cure the tumor, you end up missing a pretty big segment. That's not at all unusual, and it's one of the biggest challenges in treating tumors that involve the bone, is reconstructing the bone after the treatment and the resection has been done. Another thing, non-union, so after trauma, whether it simply didn't heal or there was an area missing to begin with, or whether part of the genesis of the non-union created a loss of bone, there can be area of bone loss here. And a different outcome, whether this is from fracture or just a de novo infection, deep infection of the bone, called osteomyelitis, can lead to a problem similar to a tumor. That in this area that you see here, if the infection is deeply inset within the bone itself, the only way to cure it may be to remove that segment of bone, very much like a tumor. And it leads to a bone defect that is similar in many nature. So with all of these different things, we're going to have bone loss. We're going to have a bone defect, and particularly a segmental defect, meaning the entire thing is missing over that area. So how are we going to treat that? Well, traditionally, the most common way, and it's still true really around the world, certainly here in the United States, the most common method is attempting to bone graft. And there are certain areas of the body where this certainly works quite well, especially in the upper extremity and perhaps in the thigh. But in the lower leg, and sometimes in the thigh, it doesn't work that particularly well, especially with larger segments of loss. Now, in the ideal circumstance, this is a great solution because you fix the bone and you put some bone graft in. There's morbidity from wherever the bone graft is taken, whether it be the pelvis by your hip, your femur, wherever it may come from. But if it works, it's a simple solution to get a healed bone. It may not look like a totally normal bone. There's a cross section in the back and sort of not fully filled in the front, but nonetheless, it's very, very functional. But that's the best case scenario. Especially in the lower leg, it's not infrequent that we have complications. Perhaps the bone doesn't heal, and perhaps that graft completely resorbs. Your body just takes it back up because it doesn't take it. That can happen. Some patients get several attempts at bone grafting, which can ultimately exhaust your options for bone graft. And even worse, there is a tendency, a significant portion of the time, for this to end in an infection, which not only compromises the bone graft, but the entire bone and fixation construct that you put into place. So we know that sometimes this can work, but it's certainly not that reliable. And if we get problems, it's not really on the table anymore as an option for treatment. So what is bone transport? So this is one of our very best alternative treatments, and in many ways, the most effective treatment. So we'll show you. It's a simple concept. For many of you who've been watching Facebook Lives from the Paley Institute before, you've seen something called distraction osteogenesis, or limb lengthening, where the bone is slowly pulled apart, and in that process, a new bone is made behind it. Well, this isn't the entire bone, because the bone is in at least two pieces. It's a segment of the bone that's being lengthened. And you can see that here. So there's been a cut made in the bone. There's a gap at the bottom. That segment is slowly pulled down to fill the gap, and new bone is made above it. So in that scenario, we have performed a bone transport and eliminated the bone defect. In principle, that's what we're talking about. Now, in this cartoon, we've used an external fixator, and that's something that we're going to progress in our conversation about the alternatives. But to begin with, let's just take one other comparison between the two. So between bone transport and bone grafting, this top section of images here are all bone grafted. These are the images taken from the original landmark article published by Lane Mascalet on the technique of induced membrane bone grafting, which is the technique most commonly used currently for bone grafting of the tibia in this case. And all of these were certainly cited as examples of great success, and in many ways they are, because they were able to get a bone that could take weight that a patient could walk on. But you can see looking at it that it doesn't look biologically normal. It's sort of bar bone, potentially subject to infection, and also alignment-wise difficult for that to maintain a straight alignment when we look at the overall position of the bone. When we look at the two cases below, what we see is the original injuries and then the final alignment and the final healing. And what's really remarkable is you see this looks almost like normal bone. And with a little bit of time, it will look exactly like normal bone. It will recapitulate the healing process of what happens as a bone develops. It will have a new cortex, it will have a new medullary canal, it will be in all regards a normal bone again. So it's fundamentally different. And that's true whether a nail's placed in it or whether a nail's not. That process will recreate the normal biology of bone. So this is the fundamental difference. Now, there are many ways you can do bone transport, but traditionally they've all relied on external fixation. You can see here a number of different options of external fixators that all have their place in the armamentarium of treatment of extremities. And certain ones have advantages over the other depending on exactly what it is, but they all have certain disadvantages. One of those is pin infections. So the site where the pins or the wires enter the skin can be inflamed, they can be irritated. That can bother a patient. It can cause need for antibiotics that otherwise wouldn't be needed. Sometimes even need to be admitted to the hospital on occasion. Not super frequent, but it can occur. And all of these things they're burdensome for the patient, for the physician, for the entire system. Sometimes, especially in the ones that drag down and bring the bone with it, we can get worse problems. That especially happens if we're transporting at 2 levels, but the pins in those situations can be more problematic and they can cause some linear scarring behind them. So in a very traditional frame, that's a real problem, and it's just something that we're faced with unless we use an alternative method. We can also have impingement of the rings on the skin, which can interfere with motion, and even if we don't get such a flagrant interference as you see here, even so the pins and wires sometimes can limit range of motion of the joints a bit, and that can potentially compromise long-term function of the joints. So these are all the issues that we really worry about with external fixation for this. We love the fact that we're able to do incredible things with bone transporting, recreate new bone, even large segments, and it works. But we have these challenges. And this really brings us to the question, can we achieve success of bone transport without the complications and inconveniences of external fixation? Fortunately, I can tell you the answer is yes. And the answer to that is the bone transport nail, which has been made by Nuvasive and Precise. I've been lucky to work with them as one of the real lead surgeons designing this device, and I am currently the world's leader in usage and cases performed in this with this device. It has been incredibly successful at being able to perform bone transport without the use of an external fixator, and that is a tremendous advantage for the patients, as you will see going through the rest of this talk. And I'd like to just highlight some of the things about how this works, about how we designed it, and about what it does for the patient experience, which I think really is critical for everybody to understand. So to begin with, you'll see a slide here, and it's not important to understand the details of each one of these things, but needless to say, it comes in different lengths and there's slightly different configurations, and it is important that your surgeon have a very good grasp on preoperatively planning these procedures. These require more thought and care and much more technical ability than any regular treatment with a normal trauma nail or other device. It's something that has to be undertaken with very meticulous care to achieve the success that it can and should have. The inner portions of it are interesting because they have these different parts. So what we have is we have a magnet, we have a gear train, and then up here we have a distraction rod. Now that distraction rod can go up or down the nail, whatever it is that we need it to do in order to move the bone segment to transport it. The gearing is what drives it, and the magnet is what drives the gearing. Now, the way this works is that there's an external device that spins that magnet inside. So there's something that sits on the outside of the leg that drives this internally, so it can affect those changes without anything going through the skin at all. When we look a little closer at some of the other design things, this nail does have a slot in it. You kind of see this here when it gets to the longer lengths. That's important, of course, for the surgeon to know, but also for the patient, because for a longer transport, we may need to go in after that first procedure to exchange a screw across the slot. And we'll look at that a little later. The reason that that slot is there is because a long slot in the nail can decrease the strength of the nail. And that was a real concern for us. For that reason, we had to add that slot in. but it does have the inconvenience of needing to be changed. Weight bearing. So this is a really wonderful thing about this device. This nail is made out of something called Biodur 108. It's a nitrogen treated stainless steel. It's incredibly strong. And for that reason, we have the benefit for that 11, 5, and 13 nail that it can really allow full weight bearing throughout the treatment process. Now in the early phases, we may not want you to put your full weight quite yet for other reasons, but it certainly would be able to in terms of the nail, and early weight bearing is possible with these. The one exception here is that 10 millimeter nail that we see. That one is only used if the bone just isn't big enough to have something bigger, and that's because it doesn't allow weight bearing until we've gone through some of the healing process. So that being said, let's look at a case example. What might this actually look like for a patient? And in this case, we're going to use an acute trauma, which is a pretty straightforward way to look at it, but this can also be used for non-unions or infections, as we noted earlier. And in those circumstances, the overall treatment is similar once we get to the point of having the established area of missing bone treated and ready for this nail. Up until that point, they require slightly different preparation, which we're not going to cover in its entirety in this talk, but we'll get a look at what would be done for the bone reconstruction portion. So after the patients come in, we have prepared the area. The bone ends have nice, relatively flat cuts to heal well when they dock. And in this case, you could see at the bottom portion, it's a relatively small piece, but big enough for us to use this device. Now, when we proceed with this, what you'll see is that we have our osteotomy at the top, and after the surgery is performed for the first 19 days, basically we do nothing. That's called the latency period. That's when we sit there and we allow early bone healing or callus formation about the area where we cut the bone. And we need to do that before we start distracting the bone apart, because we need that initial callus to form at the top that we can then distract. We then begin to pull the bones apart. And you'll see the gap here, and if you look in this area, you see there's new bone forming in there. That's what we want. Once this progresses down, and you see here we're getting near the end of that first slot, we're going to need to perform that exchange, so the patient will need to go back to the operating room. But it's a very simple operation. Basically, if you look here, we have a screw at the top that's bottomed out at the slot. We're going to, in the operating room, place a second screw. We're then going to remove the top screw, and from here we can progress with the transport another 7 centimeters. That's a very basic way to do the exchange and get 10 centimeters worth of transport. At least if the nail is at least 360 millimeters in length, we can get 10 centimeters. You see the progression there. After this exchange is done in this example, it then proceeds downward. Oops, sorry about that. It then proceeds downward further and further until we're starting to get close to ready to dock. And the next picture will show where we are basically about 1 centimeter away. When the bones reach each other, we're going to return to the operating room to clean out the scar tissue and to squeeze those bones together to get them to heal. So this is the final stage. So there are really 3 things. There was the placement of the nail with the cut in the bone, the exchange of the screws, and now the final one is what we call docking. And this is what it looks like after it's docked. We have excellent compression of the bone ends. In fact, it's hard to almost even see the fracture. It's so well adherent to each other. And we have a nice column of new bone that you can see up here that's formed. That's about 7.5, 8 centimeters of new bone. So it takes about 1.5 to 1.8 months per centimeter of bone for it to be solidly healed. So for an 8 centimeter defect, that would mean it would take us at least a year from when we started to when it would be healed all the way. However, given that we have this very strong nail in there, the patient is able to function quite well throughout that process, especially after this docking phase. The ability to weight bear really becomes effectualized quite rapidly. And what you'll see here is that after we had that period that we discussed, we would expect it to look like this, where the bone itself is healed across, and it will then mature over the subsequent years to become pretty much the same as the bone adjacent to it. So these are some of the things that we would expect to see during the process, and that's a good idea of how it would go. So some of the considerations: time. So we talked about what we call the bone healing index, which is the time it takes to heal completely per centimeter. That's pretty much the same as with an external fixator. But I like to point out that that is not the whole story. That the whole story is the return to regular function with this is greatly facilitated. And we can see that just by looking at a number of things. First, okay, if you have an external fixator, at the time you try to go to bed, there's pins and wires and things, and they can get caught in your sheets. They can be inconvenient to have when you're, trying to rest or relax. So it gets rid of that completely. There is no external device on the leg, so none of those issues occur. Also, for patients that need to wear business attire, no matter what position you're in, if you need to be out and about and dressed appropriately, you really have a hard time doing this with an external fixator on. This completely changes that. This allows that to be the case. Even if you're not returned to full walking normally yet, you still can get into normal clothes. Even with an external fixator, it's hard to get fully into normal formal attire, and it is definitely socially distracting to have a fixator on for the patient. In addition, what about travel? So if you need to get out and travel, and maybe that's a little less common in the COVID era right now, but it will return, and it is an issue, that external fixators are troublesome for this. You can travel with one, but it certainly is inconvenient. Having nothing on the outside of your leg really makes it much easier to come and go in an airplane or really any other transit that requires you to be in a given space for a period of time. So in summary, really the main messages are that the bone transport nail is really a powerful option to treat bone loss, and it eliminates the pin problems, the linear scars, and all the other baggage that comes with the use of an external fixator. There are still certain times when an external fixator is the right device, but when this is an option, it's wonderful. Easier return to life activities, I think that's fairly self-evident from what we've seen. And it's designed for up to 10 centimeters, which is a big amount of bone loss. And I would say that more is possible. The indication with the FDA is 10. We've done a lot more, and we have good techniques to do it. And what I would really sort of cement home as the final message is that for this technique and this method, the implant is an important part of it. Having it is an important part of it. But the entire procedure, the reconstruction, is more than the implant. And that this is very surgeon experience dependent. There are a relatively limited number of surgeons with a deep experience in bone transport coming from external fixation to begin with. And this is bone transport, even though it's in the nail form. That having a good experience is pretty critical to getting that long-term successful outcome. So I would really ask for you to inquire with any of your treating surgeons about their experience in using distraction osteogenesis and bone transport techniques to do these really wonderful reconstructions that can be life-changing for people with major problems of including bone loss in any portion of your body, but especially in the lower extremities. So I appreciate your attention. I certainly encourage all of you to contact us, and if you have any of these issues or you have a loved one with them, we're happy to discuss it. We also have telemedicine that is available for consultations, even if you just wanted to get some opinions on what might be possible. So the contact information is here. Once again, my name is Steve Quinnan, and I look forward to seeing you all again in future broadcasts of this type. Have a wonderful night. Oh, we're going to go to questions.
Yes.
Can't skip that one.
What is the most common age for bone transport, Dr. Quinnan?
The most common age of the patient?
Yes.
The most common age of the patient is probably around the 30s or 40s on average. There is a little bit of a bimodal distribution in that younger patients tend to be traumatic patients in their 20s, 30s, and 40s, whereas older patients can end up with this often because of some of the malignancy or infection issues that we talked about.
Is physical therapy required after this surgery?
Absolutely. Physical therapy is a big part of this. It's important to maintain the range of motion of the joints as well as the strength throughout the healing process, and afterwards to return to normal ambulation and really get your walking normal and functioning highly again.
Great. How many nights are you in the hospital after a procedure like this?
After a procedure like this, I would say most patients are in the hospital at least 2 nights, about 3 days in total time.
Okay.
All right. Well, thank you very much. Appreciate your excellent questions. Once again, look forward to seeing you all in the future.